Hi, good evening. I'm Andrea Saliba. I'm the president for ACAM Malta, which stands for the Association for Child and Adolescent Mental Health. And this is our first webinar which we are organizing. We're very excited to have Dr. Dennis Ougrin with us today to deliver his talk on self-harm and suicide in adolescents. Our mission as ACAM is to advance child and adolescent mental health through the application of research and practice. So Dr. Dennis Ougrin is currently a consultant child and adolescent psychiatrist, leading enhanced treatment service at South London and Maudsley NHS Foundation Trust. He is also a reader in child and adolescent psychiatry and global mental health at the Institute of Psychiatry, Psychology and Neuroscience at King's College London. Dr. Ougrin is the author of Therapeutic Assessment and a novel model of assessment for young people with self-harm. He also works on developing a modular psychotherapeutic intervention for self-harm and on understanding the psychopathology of self-harm in young people. As this is our first webinar, I'd like that everyone, if you have questions throughout the talk, you could type them up in the chat facility. You don't have to wait till the very end, and then Dr. Dennis will go through them and answer. If you could all keep your microphone on mute, that would be helpful in order not to distract us from the talk. And since ACAM is a voluntary organization, we would appreciate if anyone could donate through PayPal on malta@acam.org, and this would help us to keep afloat and allow us to continue to deliver high quality of conferences and teachings. So I'll hand over to you, Dr. Dennis.
Thanks, Andrea, for a very comprehensive introduction. I didn't realize it was the first webinar that you are putting together. So I'm glad I put a tie and shirt, especially for that. It has been a few days and actually maybe weeks since I had to do this. So I had a reason to do it. All right, listen, I'll just start to share the screen now. All right, and hopefully everybody could see the screen. Is that right? Can people see the screen? Or? Good.
Yeah.
Great. So look, what we'll do today is this. We will try to take you, before I even start, I just wanted to say I haven't really got a lot to declare in terms of conflict of interest, except for these two books that I wrote. I always joke that they didn't turn out to be the Da Vinci Code or any of the other, but still I get some royalties from them, so I need to declare that that I've got them. In terms of the aims and objectives for today, we'll try to look at a particular tool called Therapeutic Assessment, which is a brief intervention that you might want to deliver to young people when you see them with self-harm. And then we will look at all of this from the young person's point of view. Well, first about suicide in general. So you probably know that in most countries in the West, suicide seems to be increasing now, including young people. Look, so that's what the world looks like. I mean, in terms of age distribution of suicide, then in all countries, in all areas, more or less, you can see this pattern where you have few suicides in young people, and then as people get older, then the suicide increases. The only exception to this, interestingly, is women in Southeast and South Asia and Southeast Asia. They appear to have another peak here. You can see in young age, which is of some interest. But in terms of the suicide curves in most countries, then you will know that we haven't really made a huge amount of progress in the last years. So this is since 1980s. But in fact, if I were to take you through suicide rates since the 1860s, when the records in the UK began, this would not be that different. We haven't really done a lot to reduce suicide. There were some incredibly big variations in that period of time. So for example, during the times of both world wars, suicide rates were very low. And during the times of economic depressions and recessions, they tend to go higher. But overall, they haven't particularly changed And you probably will know that in most Western countries, the ratio of male to female suicide is about 4 or 3 to 1. That's a very consistent. That's a very consistent finding. Now, when we look at young people, the youngest people in England and Wales, then the absolute numbers are actually quite small. We see somewhere between 100 and 150 cases of suicide of children 0 to 18-year-olds inclusive, which on one hand is obviously good news. On the other hand, every single suicide is an incredible tragedy to the family, and reducing this number tends to be exceptionally difficult because of relatively small numbers. Having said this, suicide is nonetheless the second leading cause of death in young people in most countries, and which includes now the USA, which they used to have homicides, which were more common, but now it's suicide like everywhere else in the West. Number one is, of course, accidents. In terms of methods of suicide, then young people tend to follow the pattern in older people in each country. In the UK, it is hanging. That's the main method of suicide, followed by self-poisoning. And again, when you look at the distribution of suicides according to age bands, then you will see that the younger females in this case have the lowest suicide rate. But one thing to notice is that in 2018, which is the last year we have data for, you can see that the bottom line, which is the youngest females, 10 to 24-year-olds, that was actually the highest recorded number of suicide in this age group ever since the 1860s. It's really interesting that even though overall suicides in that group are fairly low, then in the last few years there was an increase, and the last available year we have the highest ever recorded rate. It's something that really is happening with young females in the UK, at least. In males, you can see again, the youngest males, boys, have not reached the highest peak rate of suicide, which actually was in late 80s, early 90s, but that is still increasing. And obviously with the COVID situation, it's difficult to know what is going to happen this year. But overall trend seems to have been towards a substantial increase. When we look at Europe, again, for the European data, the latest available data is from 2017. You can see that there is a consistent pattern of suicides being significantly higher in Eastern Europe. Lithuania tends to be the highest suicide country most years, and Northern Europe. Interestingly, Southern Europe, Mediterranean countries such as Cyprus, for example, or Italy, tend to have low suicide rate. But Malta is not like that. So when you look at Malta, which is here, and this is young people, 15 to 19-year-olds, you can see that, interestingly, it resembles rather Northern and Eastern Europe rather than Mediterranean. I don't know if any of you do research in this field. It'd be really interesting to know why you think that is. When we look at the day of the week when people die of suicide, then it's Mondays. Mondays in most countries are the days with the highest suicide rate. We have services in the Middle East where the weekend is actually on Friday and Saturday. So Sunday is the first day of work. And interestingly there, it seems that suicides are highest on Sundays. So it's the day after the weekend, which is quite a consistent finding in most countries. Young people with autism seem to have significantly higher odds ratio of suicide. And the interesting part here is that it appears that young people with low IQ tend to have odds ratios of about 2.5, 2.4. Whereas young people with high IQ, without intellectual disability, their odds ratio is closer to 10. So the risk is significantly higher in ASD in general, but particularly in the ones without intellectual disability. Now, moving on to self-harm. Self-harm is one of the strongest known predictors of suicide, which is why we study it so much. And when you look at prevalence of self-harm, then you can see that, interestingly, it is genuinely different depending on which country you look at. And sometimes the differences could be really quite striking. For example, if you look at Belgium and Holland, which are neighbors, and when you drive through them, you can sometimes even notice that you've moved from one country to another. Yet their self-harm rate is really very different. And Holland seems to have one of the lowest known self-harm rates, whereas Belgium has one of the highest. The only thing to say about this is that it is probably not just some sort of a fluke or an artifact, because if you look at many different measures of child health, Holland tends to come pretty high on any of them. So it seems to be a consistent finding across different child health measures. Now, is there anything we can do about self-harm? So up until 2015, my answer would have been no. But and me and my research group were following all of these randomized studies that are designed to reduce self-harm in young people. Now, in 2015, this is the first time in a meta-analysis that I started to say that yes, there probably is a little bit of a point in doing something. So you can see that the overall effect in this meta-analysis is just over the non-significance line, just a little bit. And you can see that some interventions are probably harmful, and some are really very strikingly effective. The effective ones with replications really only include DBT, which stands for dialectical behavior therapy. There are now 2 RCTs showing the same thing, that it reduces self-harm. There is 1 CBT study, which is as of yet unreplicated, but probably quite promising. Self-harm is significantly more common in young people with ASD. Probably about 50% of them will self-harm at some point in their life. Now, I wanted just to explain to you a little bit, when you read the literature and risk assessments for self-harm, the difference between 3 concepts which are overlapping but different. So one concept is a correlate. It's something that occurs at the same time as self-harm, for example. That would be a correlate. There is also a concept of a risk factor, and that is something that occurred in the past and is used to predict self-harm. So that's a risk factor. If you adjust for other confounding variables, it is called independent risk factor. And then there is a cause. There is a causal risk factor, or a cause. And these 3 things are quite different. So when we do risk assessments, what we would really like to have is knowing which factors are causes of self-harm. But we're not sure about that, and there are very few of those that are definitively causal. The second best is risk factors. And the kinds of risk factors that have been studied consistently are listed here. I just wanted, and you will know most of them, but what I wanted just to draw attention to is the factor of psychotic symptoms, which seems to be a very high predictor of self-harm. And a relatively new risk factor that hadn't been studied so much in the past, which is worries about sexuality and sexual orientation. And we have recently published a review looking at the relationship between social media use and self-harm as well, which could be quite an interesting novel risk factor. But the thing to remember, though, is that you remember that the base line, the base number of young people with suicide is actually quite low. Self-harm is more common, but even some of the best risk factors we've got are not going to be terribly helpful when it comes to predicting suicide. You really have to do better than what we are doing now. Some of them are strong, some of them are weak. Even if we know all of them and we assess all of them, our predictions are not going to be terribly good. We have to move away from single risk factors and move into something much more complex, such as machine learning and similar things. We know a little bit about protective risk factors. I think social support is probably by far the most important one. Now, so that's about self-harm. This is now moving from thinking about suicide into suicide attempts. So when you see a child in your clinic that thinks about suicide, can we predict which child will actually attempt suicide? And again, the risk factors will be known to you. I just wanted to draw attention to three, which are sometimes not well inquired about. And one is the exposure to self-harm in the environment of the child. And that's something that is probably the strongest risk factor that we know that determines transition from thinking to attempting. Smoking cigarettes is interestingly quite a strong one. And then drug use. And then finally, risk factors that are actually of completed suicide. Some of these will be well known to you, such as male sex is something that seems to be linked with increased risk of suicide in most countries. The kinds of things that again are often missed are things like family history of suicidal behavior, which again is one of the strongest known risk factors. And hopelessness. I was editing an issue in JCPP, which is an ACAM journal on self-harm and suicide in kids. And I remember this one paper, which I think was really quite interesting to edit and review. And that one shows the importance of social connections in those young people who are at risk of suicidality. You can see that the children with suicidality are marked in red color, and you can see that they are much less connected to other young people in schools, and perhaps a little bit more connected to each other. That's something that is of great interest in terms of preventing suicidality in kids in schools. And it appears that social connections seem to be one of the strongest known factors that determine the risk of suicidality. If you ever have the time to check out some of the new work, this is from Matthew Knox's lab in Harvard. He's trying to move away from traditional risk factor approaches, and he does something called implicit associations. They're really cool things to do. Go on the website and have a look at them. Rather than asking the child or the patient about risk factors, this one is based on implicit associations, unconscious associations between me, mine, I, and death, suicide, dying. And it's measured in milliseconds in terms of your reaction time. It's obviously something that we're not using clinically yet, but it may be the future. Now, when we look at A&E, then the repetition rate in the UK is close to 30%. It's significantly higher than what it used to be. So a child has about 27% chance of coming back to A&E in the long term. And about 1% of children will die and 50% of those of suicide, and the other 50% possibly of suicide-related causes too. Now, the things to remember about young people who come to A&E. Andrea, do you have A&Es in Malta? Is that a concept that people will know? Yeah.
Yes, we do. So we have Child and Adolescent Psychiatric Emergency Service, which is based at A&E, and it would be a team there.
Yeah, it's just some people call it ER, some people call it something else.
Yeah, same thing.
Anyway, so that's what it is. So the interesting thing about looking at young people who come to A&E and following them for a long time is that the ones who will die of suicide tend to use a method that is different from the one that they come in initially to A&E with. Young people who come to A&E with cutting, which is really quite interesting and novel, tend to be at higher risk of suicide than the ones who come with overdose. Obviously, self-harm by cutting is much more prevalent in the community, but there is something about kids who come with cutting to A&E that makes them particularly prone to actually die of suicide. So that's not trivial behavior by any means. And then, of course, a child who comes with a violent attempt on suicide or self-harm, such as attempted hanging or jumping from heights, is about 8 times more likely to die of suicide than the child who comes to A&E with a non-violent method, such as cutting or overdoses. Now, one of the problems with assessments of young people for self-harm is that up until 2011, we were really not very good at engaging them with aftercare. We are probably better now. Again, as of last year, we've been able to show that engagement is probably better with psychological therapies than it used to be, but still not perfect. And so one of the things that we did at the beginning of this work on therapeutic assessment was looking at presentations to 2 major hospitals in London. One was St. Thomas's, one is Lewisham. The numbers are much smaller. This was just around the time of the first NICE guidelines on self-harm in 2004. The numbers probably tripled since then, I would have thought. But we had 158 kids with self-harm who came to A&E across 2 major hospitals. And you can see that at the time, follow-up was offered to only half of them. That was, remember, just before the NICE guidelines mandated follow-up for these young people. And we were really quite surprised to see that only a minority of these kids actually engaged with any kind of aftercare. So a lot of the work on therapeutic assessment really stems from this problem of engagement of young people with self-harm. So what we did, we asked young people what it is that they want to get out of self-harm assessments. And interestingly, young people would usually start by saying, I don't know, I have no idea, stop asking me these stupid questions, this kind of thing. But eventually, if you ask them enough, you can arrive at some of these themes around sort of understanding, maybe feeling better. And we were quite interested to see that when you run the same algorithm with professionals, you will come up with quite different list of aims. So the therapeutic assessment really was designed as a way to really engage young people. I mean, that's the primary point of this. So it's a toolbox. It's a brief intervention that we train lots of junior doctors and lots of people who work with self-harm that they should carry around with them. When I showed this slide to Ian Goodyear once, he was a professor of child psychiatry at Cambridge, he told me, Dennis, how could you put a Stanley knife in the middle of this toolbox when you talk about self-harm? And it is true, let me tell you this, it is true that removing means of self-harm is probably the most sensible thing that parents could do in order to reduce the risk of self-harm in a child. But I also have to say to you that, of course, we cannot possibly make everything 100% safe. So if the child really feels dysregulated, really needs to self-harm, they will find a way to do it. It's not just about removing of Stanley knives from my toolbox, which I'm showing you now. All right, so at a glance, what is this therapeutic assessment? At a glance, what it is that you do your basic history like you would normally do. Then you will create a diagram. We will spend a little bit of time on creating the diagram now, which is essentially capturing the vicious cycle of self-harm. And then once you've done your diagram, you may ask the child, now tell me, where do you want to break this cycle? because if you break it, it will not work anymore. And interestingly, young people often will tell you where they want to break it. And then you might create an exit from the cycle, which is something that we will not have the time to cover today, but we might do it at some other time. Then we write a letter and we ask them to come back. So what is in essence a diagram? So the majority of the time, young people come to us with some kind of an interpersonal problem before self-harm. So very typically that would be an argument with a parent, with a boyfriend, with a teacher. It's unusual for a child to come with self-harm for some sort of internal reason, such as hearing psychotic voices or flashbacks. But they do occur, but not the majority. Now, the conflict that the child experiences before self-harm, and by child I mean anybody up to 18, right? We're not talking about little ones, then will often give rise to some sort of a negative thought or feeling in the child. And these negative thoughts and feelings typically are really quite painful. And when young people tell you that they are painful, they mean it. It's, you can do an MRI scan of the child, and you can actually see that what lights up is a very similar area to what lights up in physical pain. It's painful. So the young person will then want to do something to get away from this pain, some sort of a behavior, in our case, self-harm. And the reason why the young person does this is because typically it is linked with some sort of an improvement. Maybe they will feel less pain or something. There is always something good, something positive about self-harm, or else the young person would not do it repetitively. And equally, there is something which is negative about self-harm in most cases, which typically is in the long term. And these negative things about self-harm typically then would feel back to this core pain, to this negative idea that the child has. Right, so that's the skeleton, that's the basic anatomy of a therapeutic assessment diagram. Conflict, negative thoughts, self-harm, something good about this, something bad about this, and whatever it is that's bad about this feeds back the core pain. That's the core. So an example of this is my boyfriend dumped me, I feel worthless, I cut myself, I feel better in the short term. In the long term, I don't go out as much, don't interact with other kids as much, which makes me even more worthless. That would be a simple, typical diagram. Now, they could be quite a lot more complex, these diagrams again. And the complexity really could come if you really wanted to understand the conflict more. So when you look at what actually happens during these conflicts that are typically quite repetitive and have similar themes, then the young person will tell you that they most likely experience one of these 4 states before self-harm. So feeling rejected, overly controlled, unfairly criticized, and then a more extreme version of rejection is abandoned. And sometimes the young person will tell you that they might do the opposite to the person they're interacting with. So they might do the rejecting, the criticizing, the abusing, the abandoning first. And so that's one way to understand core, the conflict, by trying to understand these things which are called reciprocal roles. They're states of the child and the other person. And remember that we all engage in these all the time. So at the moment, I'm doing the teaching and you're being taught. And if I wanted to learn more about ACAM in Malta, I would speak to Andrea and say, Andrea, could you tell me a bit more about ACAM in Malta? And then I would be taught and you'll be teaching me. So the point is that we engage in these all of the time, but young people with self-harm tend to have relatively small arsenal of these reciprocal roles, and they're quite extreme sometimes. So the reciprocal roles would typically lead to the development of what we would call in therapeutic assessment core pain. For those of you who are CBT trained, you might see similarities with core beliefs. I'm worthless, I'm not good enough, you know, I'm unlikable, these kinds of thoughts. And then, as we said, you know, these the core pain is painful, but almost by definition, the young person wants to get away from this. Two most common behaviors in self-harm are cutting and overdoses. Both of them typically would have some positives in the short term and a lot of negatives in the long term, which then will refeed the core pain. Now, one more thing to say about the diagram is that some young people would move immediately from the core pain into self-harm. But about 50% of young people, in our samples at least, would also have this phase of bottling things up before self-harm. So the child will just gather all of these negative thoughts and feelings within themselves and not speak to anybody about this. And when that happens, we would, we used to give metaphor of a pressure cooker. If you put a lot of pressure into the cooker, it will eventually explode. But kids don't know what it is anymore, so we say to them about Coke. If you shake it for a long time, what would eventually it would explode. So that's an important thing to inquire if the child actually bottles things up before self-harm or not. And then sometimes you might have a complex diagram which might include not just bottling things up, but things like alcohol and cannabis or other types of behaviors designed to reduce the core pain. Paradoxically, of course, most of the time these sorts of behaviors will make self-harm more likely because they're disinhibiting substances rather than less likely. And I would say that the most common long-term side effect or negative effect of self-harm is actually some sort of behavioral deactivation. So the child will say that I don't interact as much, I don't go out as much, I don't do as many fun things. So you can see that in a diagram that's complex like that, one could potentially break this cycle in many different places. You know, in my clinical team, the first thing we do typically with young people is work on the behavioral deactivation and work on the behavioral activation for them. So we get them out. You know, a lot of the time they have very boring lives, just sitting in front of a computer, playing computer games, and occasionally smoking cannabis and self-harming. You know, it's not a fun, and they, you know, young people don't like that. You know, but you can do all kinds of interventions here. You can, you know, challenge the negative thoughts by cognitive interventions. You can address the conflict by doing maybe family work. You can maybe address substance misuse by tackling cannabis. By the way, young people, I don't think anybody has ever told me that they want to stop cannabis. That's that's a very unusual target for young people to have. But anyway, the point of this, it's a brief intervention, but we really want to see something that is almost opposite to the initial diagram. So we want to arrive somewhere here, where the young person feels accepted and can accept others and understand others. You know, they're aware of their talents, and then they do things they like doing. You know, it's a dream. It's something that all of us have in mind, but it takes much more than one session to arrive there. Then we write a letter to the young person specifically saying when they should come back. So, any brief questions now? Okay, I'm glad there aren't any questions because you have a task now to do. So I will now stop sharing this screen and show you a history which you should all have received anyway, but I'll just put it on here now. Right. Right, let me share this. So could you now spend 5 minutes, please, reading this history, if you haven't seen it before, and just try to create a diagram with the history that you've got here. Remember, you need conflict, core pain, and some procedures, which include self-harm, good things about it, bad things about this, and how bad things about self-harm feed the core pain. I'll just show you a bit of a video now to see how a colleague has done this, so you can compare maybe some of your notes with her work.
That's helped to sort of show how you can be stuck in a cycle. Okay. So if we start just jotting down some things. So the reason you came to see us was because you took the overdose. Explain to me what it was that was going on with you, what you were feeling at the time. My mum and me and my mum, we always argued, and this time she was just really mean, and I don't know, she just stopped giving me my money if I had no money. And I just felt left alone. I just felt alone again. I couldn't do anything with my friends. And I just felt a bit depressed. What were your feelings about your relationship with your mother at that stage? She doesn't care, and she just left me to my own thing, and I'm looking after. Okay, I'm cared for? Yeah. Kind of just carried on with her twins with girls and just left me to just get on with it. Okay. So it's like your mum is being uncaring and you're being not cared for. Yeah. Does that feel right? Okay. You talked earlier about, said something about being neglected as well. That being with my real mum. They just used to beat me and I just felt like she was doing the same thing. So there's a pattern emerging in your experience when people are supposed to be looking after you. Okay, so uncared for or neglected. And you said something about being left. Yeah. I mean, at the moment I'm just at home all the time. I'm not really going out. The girls are doing, going to school and they've got little friends, birthday parties, and I'm just being left at home. Okay. I mean, when you were referring to some of your earlier experiences, you talked about being abandoned as well. Yeah. I guess those sorts of things, that's a bit stronger, but it did feel like that at some stage. So can we put that in? Yeah. Leaving or abandoning when I was younger. Those sorts of strong feelings, how do they make you feel about yourself? What kind of beliefs do you have about yourself because of those interactions with people who no one really cares. They want to love me and look after me and care for me and just maybe I'm not worth looking after. Is that how you feel? Yeah. That's a horrible thing to feel. The being left and abandoned, but the repeated experiences of being left and abandoned and uncared for and neglected yourself made you feel like you're worthless at times. Which is quite a kind of strong. So I put here, I'm worthless. Is there something about being lovable? I don't really feel like I'm worth loving. Some of my friends, they've got boyfriends and no one would even look at me because if my mum and my dad and my big love me, I got it. Right. So when you're feeling worthless or unlovable, what kind of strategies would you use? I know we've gone over this before, but I want you to kind of be a part of what I'm doing here. What kind of things do you do to deal with that very painful experience of feeling I'm worthless? Just smoke cannabis. Yeah, just smoke weed. And watch DVDs, just smoke. Or I used to go to my friend's house. Usually I just do it now in my room or where my mum's out. So you're smoking on your own now. Yeah. So it's gone from being a social thing to, okay. So you smoke and then what happens after that? It's okay for a while, So you smoke the cannabis, that almost inevitably leads to rows with mum. Then what happens? Well, the last time I took the overdose, it was just a small one in the hospital. Sometimes I use the cut time now. I've done that for a few years now. So I just smoke. I just get a spliff and I just sit in my room and just put on some music and I just smoke. Okay. So generally what tends to happen when you've been in your room and have smoke, my mum starts, as usual, she just starts around. She starts around. What do you round up? Smoking and I'm not doing anything, I'm not going to college. She's such an old hag sometimes. I'm sure she done it when she was younger. I think she's just so hypocritical. I'm not 30 or 16, you know, but try me. Okay. So what's the kind of consequence of that row? What generally tends to happen as a consequence of your rows with your mum? Well, she keeps stopping my money. Well, okay. She won't talk to me sometimes. Sometimes she just blanks me or doesn't make me dinner. And I have to make my own dinner. Right. Which will lead you back to these sorts of feelings. So she stops your money, she blanks you, doesn't make you dinner. What does that lead to? Well, last time I just messed up the whole kitchen. Because how can she sit there and make dinner for the girls and not for me? Takes the piss. Okay. You get angry. Yeah. Right. And that manifests itself in just growls or just me lashing out. Lashing out, okay. Who do you lash out at? No, me. Lash out at yourself. Well, why do you care anyway? It's not going to change anything. I use the cutter. The cutter. Yeah. I've used it for years, and it's not, you know, it's not some big deal. So you cut yourself. Is that what you mean by lashing out at yourself? Yeah. And then what happens? Nothing really. I just don't go out. Just stay in. Why? How does cutting lead to not going out? Because if my friends want to go out, well, not that they invite me anyway now, but say if they wanted to go swimming or something, I can't go. Because I've got my arm, okay, my leg. I can't go, so I just don't go. What is it that makes you think, okay, I've got these cuts on my arms and legs, I can't go? What's that process? Because they're going to look at me like I'm kind of free. Do you do it? Do I do it? Yeah, I do. But I can see you explained to me really well why you're feeling the need to do it sometimes. Yeah, but it's not a normal thing, is it? It's, you know, after you're here, you've been with me for about an hour now, and so something tells me that there is.
Anyway, so you can see the procedure here. Final thing I wanted just to show you is the diagram that Amrit has come up with. So let me just show it to you for a second, and then so yeah, that's the diagram. Can look. Worthless, smoke cannabis, arguments, mom stops the money, child feels trapped, I cut myself, I don't interact with friends. Can anybody guess where the young person wanted to break this cycle? Which part she wanted to address? Any guesses?
Arguments with parents, perhaps?
Nearly. It's mom stopping the money that she wanted to work with. which often is an interesting starting point. Anyway, so look, I'll just stop sharing. There's a few questions. One is what is the treatment? So what about social media and Instagram? As I said, the issue is that we have got really good guidelines for suicide reporting. Now, a lot of media outlets don't follow it, but we have at least them. We haven't got really good ones for self-harm. And there is no doubt that exposure to self-harm is one of the strongest known risk factors for self-harm in young people. About treatment, I said the treatment of choice at the moment for self-harm in young people is DBT and possibly CBT with just two single positive RCT with no replications. Well done, Stella, they say. Everybody's thanking Stella, which is wonderful. What is it? Okay, what is your opinion on handling people who express suicidal thoughts without plans outside of session hours on a regular basis? Balance between keeping boundaries and giving them space to be heard. Well, remember that approximately 1/3 of young people who have suicidal thoughts will go on to attempt suicide. So 2/3 will not. The science of predicting who will and who will not is nowhere near where it should be. So I would say that all kids with suicidal thinking have to be taken seriously and treated. The most common psychiatric disorder that they have is, of course, depression. But you need to look at the entirety of the picture and treat whatever disorders that the young person has with the appropriate treatment. Andrea, anything you wanted to add? Or?
I think there's one last question about, are you anticipating a spike in self-harm and suicide during the current period?
It's a wonderful question. We have got data from 8 different countries on A&E presentations in April and May this year compared to April and May last year. No, sorry, March and April this year to March and April last year. There is no doubt that in most countries, the number of kids who came with self-harm to A&E is actually significantly lower this year than last year. But the proportion of kids with severe self-harm probably hasn't changed. And we also saw significantly fewer inpatient admissions. So whereas there is no reason to believe that young people self-harm less or are at any less risk of serious psychiatric disorders, we are probably missing quite a few of them. And which tells me that we really have to think about developing community services a lot more.
Yes, I think I agree with you, and that's the same feeling we're getting here in Malta as well.
You should contribute to our network. It'd be really interesting to have.
Okay. So I'd like to thank you very much for this interesting and very, very needed talk. I think it's given a very comprehensive way of how we can assess self-harm and suicide in young people. And I'd also like to thank Stella. The insights which you gave were things which we don't get from books and we don't get from our conferences and our lectures. So I think actually hearing it from you, I've taken on a lot of things and I'd like to then implement them in my practice as well. So thank you very much everyone for joining, and we're looking forward to organizing further webinars in the future, and we'll keep you updated about that.